Back pain is one of the most frequent companions of modern people.
Today, we will learn how experience, technology, and individual approach come together in one place, Total Orthopedics, to give people freedom of movement.
Hi everyone, I'm Dr. Aris Bertuccia. Dealing with pain can be confusing and frustrating. So today I'll be answering all the questions regarding pain management and all the therapies that we can incorporate to be treating the pain.
So can you tell us just a little bit about your background?
I'm board certified anesthesiology, board certified pain management, been practicing with Total Orthopedics for about 14 years. And we'll be incorporating interventional pain management as part of treatment of pain, working side by side with our orthopedic spine surgeons and our other sports medicine doctors.
So Aris, what are some of the biggest concerns that you hear from patients about treating pain?
The main concerns is that the pain affects patients' multidimensional daily activities, such as ability to go to work, stand up. It also affects their mental status. Pain can lead to depression, anxiety, and those other the things that we're trying to help them by treating the pain. We'll be able to make them more functional members of society.
Do you hear any concerns from patients about not wanting to get onto opioids or anything about opioid addiction?
The main concern with opioid addiction is that we've been trying to incorporate interventions, treatment of pain, such as epidurals, nerve blockers, radiofrequency. I'll be discussing in details later about all those therapies, as well as surgical referral in order to avoid opioid treatments.
And what are some of the types of treatments that you offer here at Total Orthopedic?
We start with basics injections such as epidural steroid injections, nerve blockers for patients that have leg pain, radicular pain. For some of our geriatric patients that have arthritis, we'll be incorporating facet blockers, which are injections into the joint, as well as radiofrequency ablation, which will be a longer therapy treatment for their pain, spinal cord stimulators, kyphoplasties, mild procedure, as well as Vertiflex.
So doctor, what are epidural injections?
So the epidural injection is an injection that gets performed under fluoroscopy. It's placement of steroid in the epidural space in order to decrease the inflammation that's being built in the epidural space from a herniated disc or a nerve impingement, therefore alleviating the inflammation that forms in the epidural space, or more importantly, around the nerve. And the nerve can generate pain. It can be back pain, back spasm, or any symptom in the leg or upper extremity, such as numbness, tingling, burning.
Can you tell us, doctor, what are RFA or radiofrequency ablations?
So radiofrequency ablation is a procedure that's also can be placed, it can be performed in the office as well as ambulatory center with sedation or without sedation, depending on if the patient can tolerate the procedure. It's placement of cannulas, which are definitely small needles on top of the joints in order to obliterate the nerves that innervate the joints. Therefore, the patient can be pain-free anywhere from 6 months to a year. Again, this procedure is generally indicated for patients that are elderly and that have findings of arthritis on the MRIs.
Do any patients report to you about feeling pain worse at night?
Yeah, pain can be worse at night for a good majority of the patients, especially when they sleep. Positioning on the back as well as the neck can cause anatomical changes in the background of a herniated disc. Therefore, the patient can report spasms in the neck or the lower back. For the upper extremity, can be in the scapula, as well as pain radiating to the arm, and the lower back can be lower back or lower extremity, depending on how they sleep and depending on the position. So the pain can wake them up. They can wake them up repeatedly, and therefore they can wake up in the morning and be tired and exhausted and frustrated.
Does weather really make pain worse?
Cold weather, damp weather, humidity can affect the inflammation that's been built up in the epidural space, and it can wake up the nerve pain.
Can pain affect your mental health?
Yes, so it's been proven that chronic pain can affect patients' mental statuses and lead to severe anxiety and depression.
One of the types of treatments that you offer here at Total Orthopedic is spinal cord stimulation. And can you tell us, what is spinal cord stimulation? How does that help treat pain?
So the spinal cord stimulator is, in the simple words, consists of 2 stages. The first stage is an epidural that gets performed, again, in the office. We can do it in the office or an ambulatory center. And it's placement of two fine leads in the epidural space instead of placing steroid. Now, the leads are connected to external battery, and um, the battery is being programmed by a representative from a company that provides the supplies in order to block the pain that the patient feels, whether in the neck or the lower back, or pain it's radiating to the arm or the lower extremity. The patient will go home for 5 days to 7 days and monitor if the pain will decrease by 50%, improve the daily activities, and therefore 5 days later we'll pull the leads out. And if the patient has the 50% improvement, we'll consider the implant at a local hospital.
What are the most common types of um, conditions that you see in patients for spinal cord stimulation?
The first three that come in mind, and the most popular, are diabetic neuropathy patients that wake up and they have nerve pain constant in the feet or throughout the night. Patients that have failed back syndrome, patients that have surgeries prior to, and they still have symptoms in their lower extremities or in the neck and the arms. We can recommend it. And the third will be chronic regional pain syndrome, which is a nerve injury, chronic nerve injury.
If a patient does opt to get a spinal cord stimulator, are there any restrictions to that patient's normal daily activities if they do choose to get a permanent stimulator put in?
So there's no restrictions once the patient has a implant. Um, the patient can still have an MRI. There's MRI modes. We can program the stimulator. The patient can have MRIs, CAT scan, X-rays. So there's absolutely no restrictions. They can live their life normally. They can go swimming. They can exercise. There's no restrictions. Probably just going to the airport to a metal detector. They need to present the card to bypass that stage so we don't expose the battery to the magnets.
And the spinal cord stimulator, that is a treatment that you actually perform here at Total Orthopedics?
Yes, we provide the trial in the office and again at our local ambulatory center. And the implants I do perform with the hospital, local hospital.
And how many in total have you done in your career?
About 600.
So, doctor, you had mentioned three main conditions that you treat patients with a spinal cord stimulator. Can you talk about the success rates that you see in treating patients' chronic pain with these different issues?
Yeah, in specific diabetic neuropathy patients with spinal cord stimulator, their response has been around 80% in my personal practice. And also chronic regional pain syndrome, we also have a very high percentage. I would say also in the same 70-80%. About 50 to 60% of patients that have had prior surgery also have improvement and they choose to move forward to the implant.
If I have a spinal cord stimulator, will I set off the metal detectors at the airport?
You possibly would, but if we will provide a card, the vendor will provide a card, and if you're going to a local airport, you'll present it, and you'll bypass that going to a metal detector. You'll bypass that.
Did the batteries ever die in a spinal cord stimulator?
So my personal experience is the battery can last as long as 10. The vendor recommends about 10 years. Some patients will be charging the battery maybe once or twice a week, depending on the energy that the battery may be using. Therefore, some patients will probably go longer than 10 years, and some patients will be under that time frame of 10 years.
So what happens when a patient needs a new battery from a spinal cord stimulator?
So we basically see the patient in the office. We'll have the vendor come in with the computer software, interrogate the battery. We'll make a decision whether the battery needs to be changed or not based on what the software update is telling us. And then if the battery needs to be changed, we'll schedule the patient at a local ambulatory center or a hospital where I'll be performing the procedure. I will make a 2-inch incisions, take the battery out, change the battery like you do in a remote control. And then the patient will be out in about 15 minutes.
When it comes to injections, what should people expect when receiving a pain-relieving injection?
The injections typically give patients improvement. We're looking to get at least 50% from an injection, epidural steroid injection, and decrease in pain. Therefore, some patients will have a higher response to an epidural. Some patients will get 80-90% depending on the pathology of the disc. If the patient has multiple levels of herniations, nerve impingements, then the response to that epidural may be diminished.
And am I correct that when you're doing pain-relieving injections, it's not just a therapeutic means of treating a patient, it can also be diagnostic to see where a patient's pain is coming from?
Absolutely. If a patient has multiple herniated discs and the surgeon is requesting a specific level to do a diagnostic test to understand which disc is worse, we'll do a diagnostic test. And if the patient has temporary relief with a diagnostic test, that will help the surgeon understand and move forward with the surgery at that specific level.
And one of the things that really sets Total Orthopedic apart is that it's a multi-specialty practice. Can you tell us how does that come into play when treating patients having a variety of different specialists that you work with here?
Yeah, so the idea is that we start with obviously having MRIs and diagnostic studies. We'll do a couple of injections, and if the injections help the patient, that's fantastic. And if not, then we'll recommend them to our orthopedic spine surgeons. Well, they will be evaluated, and surgeries will be provided, such as cervical, lumbar fusions, laminectomy, discectomies, and a whole multitude of procedures that our surgeons will be performing.
Doctor, what are the top three minimally invasive procedures that you see here at Total Orthopedic for chronic back pain?
The minimally invasive procedure, top three that comes in mind will be a lumbar interlaminar epidural steroid injection. It's just a simple epidural straight midline. If you want to think about it as a flood injection of steroid in epidural space, it takes about 5 minutes in the office. The second one, I would think it's a nerve blocker, which is called a transforaminal nerve blocker, which we typically perform for patients that have pain localized on one side of the back. For example, a patient has low back pain going to the left side, we'll inject it on the left side of the nerve. And then the third will be, again, patients that are elderly with degenerative arthritis. We'll do what is called a facet blocker, which is a joint blocker with lidocaine and steroid, which will be followed by radiofrequency.
Doctor, how many times a day do patients say, Doc, I'm in serious pain, but I don't like needles?
I probably hear that from about 30 to 40% of the patients.
And what do you say to patients who don't like needles?
I will tell them that I think that we will just go nice and gentle. We'll prep the back and we'll numb it nicely with lidocaine, just like going to a dentist's office. A couple of cc's of lidocaine just to numb it first, and then they will probably feel a pinch and a burn and a little tiny pressure, and we'll just guide him through the procedure nice and slow. We'll talk him through it, keep him comfortable, and again, luckily, most all patients are very comfortable.
So if a patient comes in and if they are super afraid of getting an injection performed, what, if anything, can you do here at Total Orthopedic?
So patients that will need they're afraid of needles, we'll offer them the injections to be done under anesthesia, which will be done under at our local ambulatory center with sedation, or an anesthesiologist will be giving them sedation so they don't feel anything throughout the procedure.
Do you have any techniques for distracting patients who don't like needles?
If we perform the injections in the office and the patient is awake, I'll try to talk about the life, talk about the family, the kids. We'll engage into some kind of conversation where they'd like to discuss, and keep them as comfortable as possible for those 2 to 3 minutes that we'll do the injection.
Are there any things that you tell your patients not to do that you do yourself?
So I would tell them not to run or not to go heavy at the gym, and I basically end up doing the same thing, and I hurt myself.
What are some of the burning patient questions that you get that keep you up at night?
When we do certain procedures and the patients have decent outcome, they improve, but then they come back and they are really stuck in a situation where they don't know, are they going to continue to have more therapies with me, injections, conservative treatment? Should they consider going to see a surgeon and make a decision on surgery? Those are the tough questions where I guide them to see our spine specialists, surgeons, and discuss those. So sometimes they have specific questions about surgery, and I feel like, hey, I'm being put here right in the middle of the conversation. And it's an important conversation because patients develop a relationship with you after a couple of years. But again, I'm not in a position to be answering those questions because I'm not a surgeon. So those are tough situations.
Do you have any personal experiences yourself dealing with any accidents or any injuries that have caused you to seek pain management?
Yes. When I was 24, I was in medical school. I had a horrific car accident and I had a herniated disc, an L5S1. And for the past couple of years, I've been personally suffering with back pain, where a couple of times a year, I'll be reaching out to my colleagues to get an epidural too. And it helped me tremendously being able to stand off for 10 hours a day, being able to work out, meet up my responsibilities. I find that these therapies are useful and I believe in them, and I truthfully encourage people to try them to treat their pain. For more tips, remember to click that button and subscribe.